This is looking at the higher valve gradient on long-term outcome after aortic valve repair. Actually, no one has actually seen this before. So, especially looking at valve reintervention rates in these patients. So we divided them again over a 15-year period, 2 groups. The group 1 had a peak gradient of less than 20 millimeters, around 358 patients, and group 2 had a peak gradient of 20 or more in 113 patients. Mean follow-up was again 123 months and 147 months respectively. There were a high percentage of Marfan patients in group 1, mainly because there were no Marfan patients in group 2. And the degree of severe aortic insufficiency was higher in the group 2 patients, which are the higher peak gradient patients. If you look at the preoperative echocardiography, we found that the percentage of bicuspid valves was higher in the higher peak gradient group, as well as the ventricular dimensions, again, maybe signifying that they had more complex, long-standing disease. On the other hand, looking at the aortic dimensions, it seems that the group 1, which had a lower peak gradient, seemed to have more dilated. The aortic dimensions were higher in group 1 as compared to group 2, maybe signifying that this is there's some kind of protective mechanism involved preventing from higher peak gradient after aortic valve repair. So looking at operations again, we find that when the valve sparing operation was used, reimplantation as well as remodeling, plus minus leaflet repair, that seemed to be protective against high peak gradient after aortic valve repair. On the other hand, if you replace the ascending aorta with or without subcommissural annuloplasty plus minus leaflet valve repair, for some reason that turned out to lead to higher peak gradient after aortic valve repair. So looking at the cusp pathology, that's very interesting that valves which were calcified, fibrosed, and restricted had a higher risk of having a higher peak gradient after aortic valve repair. So again, we've divided into tricuspid and bicuspid valves. Whenever subcommissural annuloplasty was performed in tricuspid as well as bicuspid valves, there seems to be a higher percentage of higher peak gradient. And also in valves where shaving and decalcification was performed, probably signifying the inherent complex valvular disease that is associated with these valves. So postoperatively, similar in terms of mortality, early complications, and aortic insufficiency at discharge. Again, looking at the latest follow-up, we find that the cardiac-related mortality, the rate of complications, and the aortic insufficiency at last follow-up was similar. However, the peak gradient as well as the mean gradient at the latest follow-up was significantly different between the 2 groups. So if you have a difference at discharge, you will have a difference at latest follow-up. So looking at the Kaplan-Meier analysis, we find there was no significant difference in terms of overall as well as cardiac survival between the 2 groups. However, the freedom from severe aortic regurgitation as well as the freedom from aortic valve reoperation was significantly better in the group which had a peak gradient of less than 20 millimeters of mercury at the time of discharge after aortic valve repair. So subgroup analysis, we looked at the group 2 patients who required late aortic valve reintervention, and we found that the younger patients had a higher risk of reintervention, but the bicuspid valves were not associated with a higher risk of reintervention. And the reasons for reintervention in this subgroup were recurrent AI in 7 patients and combined AI and stenosis in 3 patients. So multivariate analysis showed that the predictor of early postoperative higher gradient were calcified, restrictive, and bicuspid valves. And the predictors of AV valve reintervention was higher end diastolic diameter and younger age. So in conclusion, Mr. Chairman, ladies and gentlemen, higher gradient after aortic valve repair is associated with a reduced freedom from valve reintervention, especially in younger patients. Thank you very much. I thank the Society for the invitation and for Ethicon for the grant of the scholarship that made this work possible.